We're going to get started. So if you want to find your seats, welcome to beautiful Miami, Florida, Doral, technically. My name is Emmett Reed. I'm the CEO of the Florida Healthcare Association, and I want to welcome you to the free state of Florida. Are you happy to be here? We are so glad that you are here. We're excited to hear from this morning's keynote speaker, a very dear friend of mine, Governor Mark Parkinson. Governor Parkinson is the president, CEO of the American Healthcare Association, and he's been doing that for 12 years. And I will tell you that 12 years ago, the association needed a tune-up. And I will say over the last 12 years, especially the last 2 years, we could not have had a better leader than Governor Parkinson to bring us through COVID and all of the crazy regulatory issues. That's right, he deserves that we faced. So would you please welcome Governor Mark Parkinson.
I'm going to put this down. Okay. Well, Emmett, thank you very much. I really appreciate the kind introduction. It's been a great 12 years. Emmett is one of those state execs that is old school and still refers to me as governor. And, you know, as I've been here for the last couple of days, there's been a lot of people that have also done that. I will tell you that I don't do that anymore. You please call me Mark. The governor card, I actually play it twice now. Up on Capitol Hill, it still helps from time to time. All of them know that eventually they're going to be a former, so they're kind of nice to the formers. And the other time we use it as restaurant reservations. Comes in very, very handy. I think part of the reason that I'm okay in not using it is that although, you know, when you're a governor, you really do have a lot of authority and a lot of power in the state. I was also the lieutenant governor. Lieutenant governors are like the most irrelevant people in an entire state. And so I had a very sort of humbling process of going through all of that. I think it's allowed me to put the whole thing into perspective. The 12 years that I've been at ACA NCAL have been terrific. I have enjoyed it. I'll talk with you a little bit about how it's gone. The first 10 years, you know, we thought the issues were life or death. Did we get a 2.6% increase or did we get a 1.9% increase? We came into 2020 thinking that our biggest issue was, are we going to get this PDPM going to get cut, you know, 2 or 3%? And then the pandemic came along. And the pandemic really illustrated to us what is a big issue and what's not. And I'm super proud of all of you. You know, I'm a former owner-operator. I know how hard it is to do this in normal times when things are pretty good. I can't imagine what it's been like for the last couple of years. None of you have quit, and some of you have not only not quit, you've actually grown and you've prospered during what is clearly the most difficult time in the history of the sector. So I can't thank you enough for all of that. I particularly want to thank Hirsch Kroner and congratulate Hirsch. We talked about the idea of eCap 5 or 6 years ago. What he and his team have turned this into have been remarkable. I also want to thank the ambassador group. I know that some of you are part of the ambassador group. If you're not and they reach out to you, I would encourage you to explore it and take a look at it. But the ambassadors have created a partnership with ACA at the national level that if we really hadn't had these last couple of years, we would not have achieved the results that we have achieved. I particularly want to thank Mark Berger, David Hartman, and Norman Rakesh, who has now joined the ACA board. But that partnership and them raising additional political money for us, media money for us, it's been really important in our success. I want to thank all of them. Thank you, guys. Now, when Hirsch told me that he wanted me to come and do this, first of all, I haven't spoken outside in a long time, and this is fun. This brings back a lot of Kansas memories for me, because this is how campaigning was. You'd run around the state and you'd do tents and outdoor stuff. And I'll also tell you a quick story about my family. My great-grandfather, who was a state legislator from western Kansas, opened the first movie theater in western Kansas. This was like back in the early 1900s. And when they first opened the theater, they would show the movies in a tent. So I'm imagining it was kind of like this. But he had a real problem, and the problem was that the ministers at the churches in Scott City, Kansas, thought that it was a sin to go to a movie. So he lived long enough that I was actually able to talk to him about this. He lived to be 92, and I remember that, I'd sit there when I was 10 or 12 and talk to him about his life. And the way he overcame that problem was he told the ministers they could come to the movies for free. And then suddenly, it all worked out. But at any rate, it is fun to be down here. And as I was thinking about the speech, and I really didn't, I never want to dial it in. I wanted to give it a lot of thought and try to give you kind of a sense for where are we at with the pandemic? Where are we likely to go? What can you expect from the feds and from the states? And then what's the long term look like? And how do you take advantage and not just survive through this, but come out of this in as good a shape as you can? So I'm going to cover all of those things. I'm going to start out and I'm going to talk about the pandemic. Now, I decided I was going to spend some time really analyzing the history of pandemics. And so I did that. I spent a couple of days going through Wikipedia, figuring out what all the pandemics were, then going out and researching each of them. And what I was hoping was that there would be some pattern where you could say, okay, they start and then they spread, and then there's like another wave, and then they linger down, and then they're over. So that I could come and say, look, we've had 6 or 7 of these before, they follow this predictable pattern, and so we can count on this thing being over. Unfortunately, what I learned is that there is no predictable pattern. There is some news that I think we can hold with some level of optimism, but I can't sit here and tell you that every one of these pandemics that we've gone through in world history follows a set pattern that allows us to figure out when this thing is going to end. Because when you study these pandemics, what you realize is they're all different. And they react, and the public reacts in different ways. And yeah, some of the times it's been nice and tidy, like in the Spanish flu, where there was a really big wave, there was another smaller wave, and then there was one last big wave, and 2 years later, it was pretty much over. But there have been other pandemics and plagues that have laid dormant for years, and then it found some pocket of population that didn't have the immunity, and so that they've come back. And so, although I can't tell you exactly based upon the history of all these other pandemics what's going to happen, what I can tell you is that there are some lessons that we can learn from these other pandemics. One of the things I learned is that the reason this pandemic has been so damn hard to stop is that unlike almost every other in human history, it is spread by asymptomatic carriers. So normally, under normal public health, when we have a pandemic and people get sick and we quarantine them, we can keep a virus from spreading. And that's basically how many of the other pandemics have ended. Public health has jumped up and people that got the disease have been quarantined, and we've been able to end that. Part of the reason that this damn thing just won't go away is that we don't know who has it, we don't know if we have it, and it's very, very easy to spread. But the most important takeaway from all of this work that I did is that society in all of these situations eventually figured it out. Even though there were pandemics that would occur and be dormant and 5 years later come back in really, really bad ways, obviously, we're all sitting here today, there's never been one that's just come along and wiped us out. And that's principally true because generally, although not always, the pandemics become less deadly. They don't want to kill their host, because if they kill their host, they can't spread. So the survival of the fittest, the evolution of the variants tends to be less fatal, less hospitalizations over time. And it appears that we're seeing that with COVID, with the most recent Omicron variant. Now, I think an important point to keep in mind is that all of these prior pandemics, and as you can see, there have been a bunch of them, and I just listed the ones that have killed more people than COVID. There are many others that I don't list that have been less fatal. But all of them eventually ended, and until quite recently, medicine and science in general across the globe has been archaic. So we have pretty much ended these things one way or another without all the tools that we have right now. So I'm convinced, although we don't know when, that COVID will become something that we can easily cope with. It will become very manageable, and we will get back to a semblance of normalcy. Now, the thing that we don't know is we don't know when that will be. There is a possibility that it's starting now. There is a possibility that the Omicron variant was the last wave, and when people are studying COVID 100 years from now, there'll be a little chart, and it'll say, 2020 to 2022. And that the history was that we weren't really ready for a virus that spread by asymptomatic people, but we got a vaccine, we got our act together, and most people got immunized through a vaccine or because they caught COVID, and it just kind of went away as an endemic disease. That is a possibility. In fact, that's the probability. It is not a certainty, because we've seen other pandemics where they've come back and they've come back stronger. But when you look at the history, the probability is that we're on the downside. The one thing that I feel relatively certain in telling you is that we are about to enter into a period of time that I think will last for at least a few months and possibly longer of relatively low amounts of COVID. And the reason I say that is, although we haven't been very good at predicting what would happen with COVID 6 months or a year or 2 years from any given point in time, we've been pretty good at figuring out where it will be over the next 3 or 4 months. And that's because we have so much data. We can look at the case counts in so many other countries, and it's very easy to see what's coming and what's dying off and what's getting better. So if you look at the current case count in the United States, you can see that we've had this dramatic spike from Omicron that tripled the total number of cases that we'd had on any given day back in December of 2020, but it is clearly declining. Now, it's not declining as quickly in every state, but the reason that we can be so confident that it will is that when you look at South Africa, where it started, it is now declining dramatically. Case counts are down over 90%, and in all probability will continue to fall. We're seeing this same pattern in New York, which I think was probably the first state that got hit by Omicron. We're seeing the same pattern in New Jersey, same pattern in Massachusetts. Emmett, I know in Florida it started to come down quite dramatically. And so I think that we could have some level of confidence that this is going to happen. Now, I told our board back in July of 2021, we had a big meeting in Florida that Emmett helped us host, and folks thought COVID was over. I stood up and I said, I hate to wreck this meeting, but I think we're in the 5th inning. Because if you look at what's happening across the globe, we're going to get Delta in a big way. And unfortunately, I was right. And then in early December, we rang the alarm bell for our members on Omicron and said, it's coming, and it's going to last about 2 or 3 months. And unfortunately, we were right. And as negative as that news has been, I think the positive news now is that for at least the next 3 or 4 months, we should be in an area that's pretty good with COVID, and it may last much longer than that. This is the time to hunker down, to do everything we can to get our workforce back, to get our census back, because I think we're going to be in a pretty good shape for the short-term future. The other thing that we have learned from Omicron, and this is very common in pandemics, is that we're fighting a much different virus than what we were fighting 2 years ago and even last year with Delta. The early reports in South Africa were, hey, we got a ton of cases, but we're not putting these people in the hospital. Well, fortunately, those early reports ended up to be the case. This is a study that was reported by the New York Times that looked at data on people that were vaccinated, not vaccinated, getting COVID, et cetera. And what it basically shows is that the fatality rate of COVID now falls into a range of what we would expect to be behaviors that we can accept and tolerate and not fundamentally change our lives, and for life to continue to move forward. They figured out that a 65-year-old vaccinated woman who got COVID had a 1 in 872 chance to die. 75-year-old woman had a 1 in 264 chance to die. You compare that to the flu season, where 65-year-olds had a 1 in 138 chance to die. COVID, at least as it exists right now, is well within the normal risk factors that we accept every day. Another analysis that I read last week said that if you were a vaccinated person in the United States your chance of dying in a car accident are now 2.5 times higher than your chance of dying from COVID. And obviously none of us is avoiding cars. It is a risk that we are willing to accept. So I think what is likely to occur here is that COVID will be down for a while. It may come back, but as long as it comes back with this type of variant, at a level of mortality that is acceptable to us, it shouldn't be wrecking our lives and it shouldn't be wrecking our businesses. Unfortunately, it has been. Even the most recent Omicron variant has finally found its way into nursing homes. This is the chart of nursing home cases among staff. You can see that we experienced a dramatic spike 3 or 4 weeks ago. It is now declining. Similar is the case among residents. But the good news being, we're just not seeing the hospitalization and the deaths of residents. Okay, so does that mean everything's great? No, everything's terrible, because COVID has wrecked our businesses in 2 significant ways. First, it has destroyed our census, and second, it has killed us on labor. And I know that you all know that, but just so you'll understand that everybody else is in the same boat, I'll show you the data. So what happened with COVID was that immediately after it hit, we saw a pretty rapid decline in census. We actually held our own until the Delta variant came. We held our own until, it wasn't the Delta variant. In the fall of 2020, we had another big wave of COVID, wasn't Delta, and we had another gap down in census. We'd stuck around 72, we gapped down to 67. That was the bottom. First half of 2021, we're recovering. 0.1% a week, 0.2% a week. Like clockwork, we're moving up almost 1% every single month. We get to July, we're up to 72.5%. Not very many people are getting COVID. We're feeling like this thing is over, and then boom, Delta comes along. And since the Delta variant, we have been completely stagnant with census. This data is really good because it's the NHSN data. Every building in the country reports every single week, so we don't have to extrapolate. We know exactly what census is, and we're really in trouble on census. This has to keep growing. There isn't enough money that Emmett can get in Florida and that we can get at the federal level to fix the problem if census doesn't start to grow. The second area is in labor. And again, if you're struggling, you're not alone. Everybody's in the same boat. The interesting thing is that when you're talking to policymakers who say, yeah, you're complaining to me about workforce, but everybody's in the same boat. No, everybody is not in the same boat. There has been an overall decline of healthcare workers, but it's mainly been us. We've done a deep dive into the Bureau of Labor Statistics data, and what it shows is that in outpatient care, in physicians' offices, in home health, and in hospitals, you can see the charts, they basically have the same number of workers now that they had before the pandemic. The change in labor patterns is uniquely tied to long-term care. And unfortunately, in the nursing home world, and again, this is Bureau of Labor Statistics data, we're not guessing, we're not extrapolating from some small sample size, 220,000 jobs lost in nursing homes. In assisted living, 38,000 jobs lost in assisted living buildings. Huge, huge problem that has had multiple ramifications, and I know how tough it's made running your business. So, how long is it going to take us to fix this? And this falls into the category of something that we don't know. But again, I'm going to give you somewhat of an optimistic spin on this thing. We don't have to guess what census recovery will be like when the world feels like we're back to normal. So let me just let you process that for a minute. When folks feel like COVID is somewhat behind us and that it's safe to run around and do stuff, and we can do elective procedures, and we can send people to nursing homes, and we can send our mom and dad to an assisted living building or to a nursing home, and it's safe, we don't have to guess what the census recovery is, because that's where the world was at in the first half of 2021. We thought this thing was over, and so we were able to see what behavior is, and what behavior was that we recovered at about 1% a month. Once society decides that things are pretty safe and that we're getting back to normal, that's what's probably going to happen. Now, is it going to be 0.2% a week? Is it going to be 0.1%? We don't know, but I will tell you it makes a massive difference. Let's go back to the chart. If we could have a 0.2% increase starting now, it would take us until October to get back to full census. If it takes us if we only get 0.1%, it takes us over a year. So the question is really not how long is it going to take? The question is, at what point do we start feeling like life is back to normal? Society is not there yet. Kids are still wearing masks in school. People are still freaking out when they get on airplane. I mean, society isn't quite there yet. eCap's there. I think there's a lot of hugging going. eCap's there, but I don't think the rest of the world is quite there yet. Once the rest of the world gets there, people will come back to our facilities, assuming we have the workers to take care of them. And that's because, as scary as it is for folks to think about putting parents in their nursing homes under normal times, but certainly after COVID times, they need us. There are just a ton of people that just cannot be taken care of at home. And all the talk about the baby boom, and I've been tired of hearing about it for the last, my whole 30 years in the profession, it's really going to happen. The silver tsunami is really going to happen. In 2025, the oldest boomers turn 80. And the number of people between 80 and 85 over that next 5 years goes from like 6 million to like 8.5 million. And the 5 years after that, it goes to like 12 million. So if we can hang in there and survive through this horrible time, we are going to be okay. But I know that surviving through this horrible time is not a given. So what are we going to do? How are we going to make this work? Well, I think Emmett and I see Rick Abrams here, and Stephen Hans is here, there's a number of our state execs. We know that our job is to get you as much money as possible to give you the best possible chance to last until we get to census recovery. Now, we can't keep getting these special payments after we get to census recovery, but the whole idea that we've been fighting for the last 2 years is how do we get more money in our members' pockets so that census can come back? And that's why last year was so damn discouraging, because we thought that we just needed to keep the sector propped up until the end of 2021. And then Delta came along and we realized, no, we got to keep the sector going through 2022, and maybe we'll have to keep the sector going up through 2023. So job one is, how do we survive until census recovery? After that, then we can look and start working on this second bullet point, which is fixing the chronic problems with Medicaid. And in the meantime, for you to survive and for you to make it through this, you got to make a bunch of really good business decisions. And I'll talk about those in just a second. So how are we doing with money? Well, in 2020, ACA was a hero, right? We were your favorite 4-letter acronym because we had a great relationship with the Trump administration, and we were able to work with Secretary Azar and Administrator Seema Verma, and we were able to get people the funds that they needed. And I won't go through the details of all of them, but obviously it was a pretty good year. 2021, we're not so smart anymore. We're not getting very many of those monies and fundings at the federal level. But the good news is we figured that out. After Biden got elected, it was very clear that with House and Senate leadership and with President Biden, they weren't going to go in the direction of federal relief to providers. But they did send $350 billion to the states. So we went to our state execs and we said, look, we got to give you guys the baton. We're going to keep trying at the federal level, and we did get a little bit of money. But what we really need to happen is we need the states to come through. And this is where having 50 state affiliates is a really big deal. Because in a number of our states, not all, there are some very bad governors out there, some of whom have resigned, no names will be given, that haven't helped us, but for the most part they had. So in 2020, the feds were the heroes, $13 billion from the Provider Relief Fund, but our state stepped up and did over $10 billion in 2021. So what's the plan for 2022? We're going to try to play back what happened in 2021. We continue to work with our state execs to do everything that we can to help them with their journey in getting these funds. Many of them are doing it without an ounce of help from ACA. These state execs and these state associations deserve a ton of credit. But when we can help, we are. So we've hired a couple of really good lobbyists, including Jim Carlson, who was the former state exec in Oregon and really good, to run around and work with our state execs. Our board has allocated $5 million from our reserve to spend money helping states with their state programs, and we're seeing real results from it again in 2022. At the federal level, we're working principally on 3 different things. The first and probably most important is to keep the public health emergency going. Many of you have buildings in states that have had Medicaid increases that are tied to the public health emergency. All of you are in states that are getting extra Medicaid money because of the public health emergency. The public health emergency is also what allows for the waiver of the 3-day stay. And ACA created the temporary nurse aid program. We put it up on our website. We said, hey, if you want to get training, do it. 250,000 people took our training. 200,000 of them are in buildings right now. The continuation of that is tied to the public health emergency. So first and foremost, we got to keep this thing going. Good news, 2 or 3 weeks ago, HHS extended it for another 3 months. They can only do it 3 months at a time. We go up on the air in a couple of weeks with some ads in DC, encouraging them to extend it in April. We think there's a pretty good chance they will. That will get it into July. Once we get into July, it's hard to tell. A lot of it will depend upon the data, how much COVID is out there. Does the administration feels like it needs to kind of do a mission accomplished type thing and end the public health emergency? It's hard to say, but we are super focused on keeping that thing going. The Provider Relief Fund has been disappointing, and I know that. And I know that, hopefully all of you received some level of payment here in the last month or two. It's not enough. We need more. It doesn't have money left, so we're renewing an ask on Capitol Hill to get more money added back into the Provider Relief Fund. It's going to be hard to get it done because Congress is not able to pass any bills right now. Even if we can convince them, it's not clear that they can pass a bill and get this done. And finally, the issue that we thought in 2020 would be our #1 issue has percolated back, and that's PDPM. PDPM has been good for our residents, it's been good for providers, it's been good for the sector. CMS believes that we're getting paid more than we should. We're getting paid more than what we were under the old system. They didn't cut us in 2020, they didn't cut us in 2021. There is a chance they will cut us this year. We have a plan, we're working on it very hard. We will know on May 1 when they issue their preliminary rule, but we're quite focused on making sure that PDPM is not cut. Post-pandemic, what do we do? You don't have to be in this business for very long to realize that we don't really have a Medicare problem, we have a Medicaid problem. In most states, Medicaid underpays what it costs for us to take care of residents. That's not a very good business model, it just doesn't work out. We got to fix that. People are constantly saying we need to have federal Medicaid reform. And what I need to tell you is it's probably not going to happen at the federal level. When you look at the inability of the feds to pass any legislation and to get along, even when one party is in complete control. The Republicans, when they had it for 2 years, couldn't do very much. The Ds, they've had it for these 2 years, they can't do very much. And then when there's divided government, they can't do anything at all. That tells me that we're not going to solve this problem at the federal level. If we're going to solve it, it's going to be at the state level. The good news is it is solvable at the state level. I mean, Emmett's a great example in Florida. Emmett came in here, 10 or 12 years ago. Florida was really struggling. You get a great leader, he brings the members together, they develop our Florida promise, they start doing an outsized amount of political activity, and you can really start to move the needle on Medicaid. We've seen the same thing in other states. States that are struggling on Medicaid, the members get tired of losing, they quit fighting with each other, they come together, they start doing outsized political activity, and good results occur. And that's why at the national level, we've really turned our focus on the states. What can we do to make sure that there's not just a handful of states where people break even on Medicaid or even make a small amount of money, but that is the norm. And as impossible as it probably is to fix it at the federal level, with united members being very involved and getting very politically active, we can solve this problem, and we proved that time and time again at the state level. What do you do as an operator? Well, the pandemic has demonstrated that there's a huge disparity in the success of operators. Some of them have already gone broke, some of them are about to go broke, and then there's another class of folks that are doing really well. So I have a bullet point on here that says it's okay to copy success. And let me tell you what I mean by that. There's a group of companies that are hyper-focused on leadership. And it's companies that primarily come out of the West. And I'm talking about like Ensign, Providence, Cascadia. These are people that all kind of came from the same group of folks. They're deeply into all these leadership books, and they just live and breathe leadership. You don't have to wonder how they're doing because Ensign is publicly traded. And the thing that's interesting about Ensign is Ensign has not only survived during the pandemic, they've prospered. You know, go to a financial website and read their earnings reports. Look at what they're doing. Thank you. And it's phenomenal what they've been able to accomplish during the pandemic. Really remarkable. They've done it because of a hyper focus on leadership. They've incentivized the people that run the buildings, and they're getting incredible results. There is another set of operators, none of whom are public, so it's a little harder to figure out how they've done it, that have been really smart on ancillaries. They don't make money on their core sniff business, but they figured out that if they develop eye snips, I'm okay. I may look like I'm melting apart back here. I'm fine. This is Kansas. You don't even get votes until you start getting lathered up. I am fine, but thank you. I'll drink some water so I don't pass it on. I'm just fired up today. Anyway, they're doing it with ancillaries. So they're not making money on their sniffs. In fact, there are some folks out there, and maybe there are some in the room, that are willing to acquire sniffs that they'll break even or lose money on because they want to use it for their pharmacy, their home health, their rehab, or their eye snip. And then there are some people that have figured out both of these things. They've figured out that if you can incentivize leaders and hire great leaders to run your buildings and focus on metrics and really measure things and do great things, and also figure out how to either own or get a piece of the ancillaries, those are the people that are really killing it. And so I think a great thing about a conference like this is talk to each other, figure out, who's killing it, why are they killing it, and what should I be doing? And there are vendors here that offer some of these services. There are folks here that will help you set up an iSnip or become a part of an iSnip. There are people that will help you with pharmacy, et cetera, et cetera. As bad as it is, there are still some people that are doing well, and it's because they're smart and they're making smart business decisions. So, as I think about where we're at right now, I think it's remarkable. If you would have told me a little over 2 years ago, which was a glorious time for me, the Kansas City Chiefs had just won the Super Bowl, and I was like in heaven. I'd heard about COVID, but it didn't sink into me in February until Kirkland occurred, what we were up against. But if you had told me 2 years ago that there was going to be a pandemic worldwide that was relentless and it spread asymptomatically, and that older people were particularly impacted, and that over 200,000 people would die in American nursing homes, I would have thought, man, bring on some more of this food. This is it. The sector's not going to survive. Well, the sector has survived. And some of you haven't just survived, you've prospered. And that's been inspiring. Because you've survived and because you've prospered, hundreds of thousands of lives have been saved in buildings. They have. But we're not done yet. There's still a lot of work to do. And I know you're not going to quit doing the work. And Emmett and Rick and Stephen and I, we're definitely not going to quit doing the work. We're going to keep fighting on your behalf every single day until we get this thing behind us. So thank you all very much for what you're doing and for the honor to represent you. Thank you. I think we've got a little bit of time. If anybody has any questions, I'm willing to take any easy questions, any hard questions. We're going to turn to Emmett. Yeah. I don't know if we have a mic that we can pass around.
Thank you very much. A quick question on the states that do the IGTs. Any chance that on state level we'll may see an increase in Medicaid rates?
In the states that have IGTs?
Yes.
So are you talking about like Indiana or?
I'm sorry?
Are you talking about, tell me what specific states you're thinking about.
A state of, like, let's say Texas.
Connecticut and Texas?
Texas.
Texas? Texas is an interesting state because Texas is a state that before the pandemic, I would have said, wow, this is a really, really hard state. Because we've had a lot of Medicaid battles in Texas that haven't been successful. But then lo and behold, the pandemic comes along and the governor decides to be helpful. And so you can have like a $23 a day add-on somewhere in that range. $19 a day add-on that's tied to the public health emergency. I think that, as I said before, we can keep the PHE going on for a while. And then the issue is for this legislative session and next year is can we get them to keep that in the rate? And that's the battle. And Texas is a challenging state because it's one of those states where the members have not come together. There are about 1,000 nursing homes in Texas. We only have about 350 of them in our association. There's another group that has about 200 buildings, and then there's another 400 or so that are in none. The long term of success in Texas is very dependent upon them all coming together. But in the short run, we're going to continue to do everything we can, and I think there's a fighting chance to keep some of that increase in the rate.
Thank you very much.
Yep.
Hey, Mark. Thank you, as always, for your leadership. You are inspiring.
Thank you.
And perspiring. Yeah. So I'd love to hear your comments about the ironic, somewhat painful timing of having publicly available staffing metrics now on Care Compare in the height of the worst staffing shortage, and in 6 months they're being added into 5-star. Just your thoughts on that.
Yeah, it's bad. And the backstory is Congress passed a law 5 years or so ago that required this data. And frankly, they required CMS to report it. CMS got too busy during the last couple of years of the Trump administration, last 3 years, and just basically said, we'll look the other way on this. The new administration came in, they told us they were going to do it. They didn't do it last year. We thought they would do it this year. We were hoping they would wait until the fall, and they didn't. I agree with you, it is completely tone deaf to the realities that are occurring out there. It is symptomatic of the fact that we clearly have some challenges with CMS. We've got some relationships that we need to improve, but I agree with you, it just makes no sense at all.
Hey, Mark.
Yeah, hey, Rick.
Two things. I just want to echo what you've said about the importance of political galvanization, and just a shout out to the ambassadors group. In Wisconsin, we were able to achieve Medicaid increases embedded in the rate, just historic increases, on average 12% per nursing facility. And I must tell you that working with the ambassadors group and the members, the joint members who are part of that, they really, really galvanized it. So we were able to exceed our political giving, if you will, 4 or 5 times over what we were able to do historically. And if you want to use Wisconsin as a case study, it absolutely worked. Now, we were so bad, we've got a lot of work to do. But, working with the ambassadors group, getting your members to understand the importance of the political process, absolutely key. So that was the comment or the commercial. My question is this, is that, when I represented long-term care providers over 15 years ago, Medicaid was a problem, not surprisingly. It still is a problem. So my question is that do you ever see a day where we're less dependent on governmental payer sources and more dependent on things like private insurance and other and other payment sources to get us out of the morass of constantly having to have our hand out with government? Thank you.
Yeah, I mean, I really don't. And I mean, I know that's discouraging, but long-term care insurance has kind of had its day and it didn't really work. And it'll have starts and stops, and there will be some people that'll get it. I'd be surprised if it was ever a material payer for us. I think we're stuck with the Medicare and Medicaid thing for a while, but I also think that it's going to shift to a payment, not next year or the year after that or the year after that. It's going to shift to a payment that's based on population health management, because that just makes so much sense. Eventually the system will get there, and people that are really good at population health management, they'll start doing really well right now because they'll prosper with their ISNPs, but there will be more of a focus on that year after year after year until eventually we'll have a rational system, and the system will save money under that sort of system, but good providers will make more money. Bad providers will make less.
Thank you. Not really a question, an observation. I'm a bit more optimistic about the pandemic. The mRNA vaccine capability is highly flexible.
Unbelievable.
And we now know that for hospitalization and death combined, the unvaccinated are 98 to 99% of that population. And we now finally have 3 effective therapeutics that are easily available. If you combine the two, I think you're absolutely right that the mortality and morbidity index is going to plummet. And I'm anticipating that summertime, this starts looking like it's in the rearview mirror.
Yeah, I really hope you're right. I had a slide this time last year where the headline was, "The clinical nightmare is over." So I've just decided I'm going to be a little more humble in my predictions, and I think you're probably right. I would put that in the above 75% category. But there have been pandemics that have come back worse, and what it would take, obviously, is a variant that's more deadly that can get around the current vaccine and can get around whatever protection we've been given. Most of the planet has probably had Omicron at this point, so people have some immunity and antibodies whether they've been vaccinated or not. I think I think you're probably right, and I certainly hope you are.
With labor and agency price gouging, can you talk a little bit about that? What AHCA is doing, and census can come up, but we just can't afford to keep paying these prices. So, if you talk a little bit.
I think if there's hope there, it would be kind of in 3 areas. The first is that, I'm 64, I've seen a lot of things, and things do adjust rapidly sometimes, but usually when that occurs, it's not permanent. There's some reversion to the mean. So this enormous loss that we've seen in jobs all at once, I think some of it will naturally come back. It won't all come back, and it won't all come back at the same time, but there'll be some reversion to the mean in people's behavior. Some of that will be dictated by changes in policy. Until February, the child care tax credit was out there, so every person in America, basically, unless they were in the top 10% of income, got $300 every month for every kid they had. That had a big impact, I think, on the workforce. I think as we get into February, March, April, people will start to realize they got to go back to work. So I think in one respect, there'll be some natural reversion to the mean. Secondly, there will be some changes in policy that will help. We are attacking the staffing agencies. At the state level, I think there's a real possibility for some caps to be instituted in certain states. Probably going to take a very Democratic, a very blue state to do that. Most Republicans don't like to impose those kind of restrictions on the marketplace. But if you have buildings that are in blue states, I think one of the things that you'll see is more of a public policy attack on the staffing agencies. We're trying to do what we can at the federal level. One of our organizational goals this year is to get a hearing that will shed some light on the whole topic, which I think will help. But legislatively, the solutions will primarily be in blue states at the state level. And then the third thing is the free market. It's so incredible that whenever it sees an inefficiency, it gets filled. And so organically, there are companies that are coming up, and I don't know if any of them are sponsoring this event or not, that really take the staffing agency out of the equation. Now, it's not as good as it was before all of this, but there are companies that are sort of developing almost an Uber-type solution where buildings sign up, staff sign up, and then you enter into kind of a direct negotiation on what shifts will be filled and at what rate. And then the companies that put the technology together are taking like a $5, sometimes in some cases as little as a $5 a shift add-on. That's a lucrative area, and I think we'll see growth in that. So I think the staffing agencies got too greedy, and they got greedy enough that the marketplace recognized it and is going to fill that gap with a solution. But big solutions like immigration reform and suddenly bringing us hundreds of thousands of additional workers, they aren't out there. So as an operator, I think what you need to do are a couple of things. First, you've got to be hyper-focused on employee retention. Now, I know that that's not a fun thing to hear because people just want a solution. How can I suddenly hire a bunch of more CNAs? But I will tell you that turnover rates in our sector range from people that have less than 25% turnover a year to people that have 100 or 200% turnover a year. You can get really good at keeping employees satisfied and engaged and get yourself into that category where you're just losing less people. Norman Rokish from Marquis, I think somebody from his company today is going to give a speech here a little bit later on that's going to talk about how they've been able to dramatically lower their turnover through a hyper focus on employee retention and turnover. The other thing that you can do is that there are companies out there that will help you identify nurses, particularly foreign nurses. There are a lot of nurses in the Philippines and other countries that want to come here. The very progressive companies have enlisted those folks to go out and get them on the list and get them signed up for foreign nurses. It's a very long process. We've now gotten involved to try to speed that process up at the embassies and with some of the interviews. But if you're not doing that, I would encourage you to look into that as well. If you get really, really good, it can actually, in the long run, become a competitive advantage. But right now, I realize it's a crushing problem for the whole sector. Even people that are really good at employee retention are not able to add to census because of a lack of workers. It's a massive problem that I don't know the solution to, but hopefully some of the things that I said will help.
Yeah. Hi, Mark. You emphasized how important the federal emergency is for the, I think because of the federal dollars that are going to the states to support the Medicaid programs and enhanced rates and reimbursements. You told us about your plan that might be extended through as far as June or July. But post that, is there any chance that the nursing home funding that comes along with that federal emergency gets decoupled from the emergency at large? Is there any way that there could be a nursing home emergency? I don't know, like a temporary extension that federal support continues for some period of time beyond the overall country's emergency, which probably has much bigger political issues at play.
I think there is. I think there is a chance that some of the good things that come with the public health emergency can be extended. So one of those things is the temporary nurse aid program. And we're really encouraging CMS, and then I know a number of states are working through their state regulatory people to be able to extend the TNA program or extend the time that temporary nurse aides would have to get the training to fit their regular requirements. I think the Medicaid increases that some of those things have a chance to last. And again, a number of our state execs that got one-time payments are trying to get those built into the rate. Now, some of them are doing it like Emmett's been doing it. He's been getting it built into the rate all along, which is very, very helpful. And then finally, there's the issue of the 3-day stay. The good thing about the last couple of years is we're going to have a lot of data on what the impact of the 3-day stay waiver has been. We are hopeful that it will show that it's an overall cost savings or at worst a neutral to federal spending. And if that's the case, then I think we have a real shot at getting it extended as well.
Sorry, one follow-up question from that. I understand that the states might extend some of those currently temporary rate increases and make them permanent, but wouldn't that funding have to come from the states then if they lose the FMAP increase that comes with the emergency?
Yeah.
So I guess my question is there a chance to extend the federal dollars going to the states
Yeah.
for some period of time?
To get a permanent Medicaid increase to the states would take legislation. And I just don't think it's going to happen.
Even if it's just an extension of the emergency for this industry?
Well, one thing the Biden administration can do, and this is the reason I'm optimistic about being able to keep getting the public health emergency extended, is every time they extend it, and they have the authority to do it, that allows this Medicaid money to keep flowing. They're very pro-Medicaid. They want Medicaid money going to the states. So I think that there's a chance that they will just keep extending it, and then there'll be like litigation and arguments over how long can they keep extending it. But they don't have the unilateral ability to make it permanent. Only Congress can do that, and Congress is not going to do that.
Thank you.
Mark, first of all, I want to say thank you. Your support has been unbelievable over the last 2 years. It's been a nightmare, but we really feel the National Association doing good work. I want to ask a follow-up question about the federal emergency, healthcare emergency. You mentioned that we have network industry-wide about 200,000 non-certified aides working in our buildings under the 1135 waiver. What happens when they turn off the emergency? Do we have to give up all of those aides? And that's going to be game over for the industry. 200,000 people exiting on one day.
Yeah, it would be disastrous. One of the things I want to do, first of all, is I want to pat ourselves on the back a little bit. I had absolutely nothing to do with this, but our clinical people figured out early in the pandemic that there was going to be a real workforce problem. So I'm not sure people know this, but ACA developed that program. ACA developed the training. We went to CMS with the idea, and CMS said as long as the states will go along with it, that's fine. We put it up on our website. We said you don't have to be a member. Anybody can come on. They can do it for free. 250,000 people trained, 200,000 people in buildings. I'm not sure I've ever heard of an association having that kind of impact on a workforce issue. Now the issue is, how do we transition those people into either certified med aides, certified nurse aides, or some other certified category? And that's why if you got them in your buildings right now, anything that you can be doing with them to get them into classes so that they can get that training is great. We're finding some success at the state level. I think Kansas, I don't know if people, I know there's some folks here at eCap that have buildings in Kansas, but Kansas I think is now the first state that's just extended it beyond the public health emergency. And we're trying to get other states to do that as well. Again, CMS does not have the unilateral authority to do it without Congress passing a law, and Congress isn't going to pass a law. The advocates, the people that criticize us all the time, they're pounding the table really hard over at CMS for them to get rid of the program right now. So we have some real challenges to this in DC. But again, at the state level or as an individual operators, you've just got to transition those workers into certified workers. And hopefully we'll buy you some time to do that.
Mark, this is a little bit afield of your normal regulatory and reimbursement, but let me ask you a question in two parts. You mentioned in one of your latter slides, you talked about doing deals where someone's not going to make money, but they're going to make money on ancillaries. So number one is, how do you think those deals are getting done? And number two is, the ancillary ecosystem that seems to work for larger operators, right? If I have 100 buildings, I can have my own pharmacy and therapy and so on. How is a smaller operator to get in on the, ancillary ecosystem game? I don't want to call it a game, but the game where they can, not make as much money in the nursing home business, but have their other businesses that are feeding into that.
Well, there's no question that for every ancillary business, you have to have a critical mass. I'm not an expert in what that critical mass is for each segment of the ancillaries, but I do know from talking to many members that if you have a concentration of buildings in a specific market, it doesn't have to be 500 buildings or 100 buildings or 50 buildings. If you have 5 or 6 buildings in a specific market, you are clearly a candidate to be involved in an ISNP program, whether it's signing up with one of the programs where you're part of their ISNP or whether it's developing your own ISNP. The first ISNP was started by a provider-owned ISNP was started by a rural provider in southeast Oklahoma who has 6 buildings that are all like 50 miles apart from each other. I think the same is probably true in pharmacy, although again, I'm not an expert on this. I doubt, I don't really know. I suspect that you can't develop your own pharmacy in a given market with 5 buildings, but you can become a part of some other pharmacies that are out there that will cut you better deals or bring you in on the deal, even though you might not have a critical mass to do it exactly yourself. So again, I'm not the expert, but even if I just had the little operation that Stacy and I had back in Kansas, which was 6 buildings, I would be investigating every one of those ancillary opportunities to determine if I was big enough to get a piece of a business that's a better margin business than the SNF business. And I think you'll be surprised to learn that you can be pretty small and still be involved. Anything else? Okay, I think I finally stopped sweating. Apparently I'm going to survive another day, but thank you all very much.